experience in this symposia. And as you know that 18 to 26% of our cath lab patients have moderate to severe calcified lesions. So this is very challenging and difficult situation, and this is a very time or the situation, I will say that. And most of the lecture will be focused on the heavily calcified lesions. Now I am requesting all of the participants to put your question in the chat box. Can I request now our first speaker, first speaker is Dr. Hirakawa, the role of IVUS ISD for the complete imaging. Or is there any comments from the chairperson? Is there any chairperson to give a comment, and then the speaker can talk? Honorable chairperson, do you have any comment for this?
May I make a comments? It is good afternoon, and it is a very great pleasure to be a chairperson of this August gathering, along with Professor Sophia Rahman, Dr. Samuel, and the Professor Mamun Rashid. So just to say hello to everyone, and as Professor Afzal said, I hope that this will be a very good sessions, interactive sessions, and the participants will learn a lot from these sessions, which can be applied in the practical day-to-day practice. Thank you very much. Thank you very much. Welcome everyone to this session.
Now, is there any other chairperson? Is there any comment, or should I go for? Should I call the speaker, sir?
Assalamualaikum. Good afternoon. Thank you for having me in this session. And as you say, we have all renowned cardiologists from home and abroad. Hope this session will help us as well as our fellows and others interventional cardiologists in this country and abroad. So I welcome on behalf of the society everybody in this session, and we hope that it will go nicely and in time as well. Thank you, Dr.
Thank you, ma'am. Professor Matthews, would you like to say some comment, or you will take on your talk? Hello. Professor Matthews.
Hi, Sophia and others, and Dr. Rahman. It's a great pleasure to be with you all, and let us share our knowledge and improve the outcome of the patients in both.
And Caesar, Mamunur Caesar, chairperson.
Sir, thank you, sir. We all are from morning, and BSCI organized a very beautiful program. And with us, there is a legendary intervention cardiologist like Matthews. I saw that he's one of the most pioneer and brilliant person to tackle the calcified lesion. With us, Fazilatul Nisa Malik, Nikhil Panchali, and Mojmun Jaman sir. I think that this session will be highly interesting and fascinating. Thank you, sir. Sir, unmute, sir. Abdullah, sir, unmute, sir.
Now, rest of the expert panelists, I will put you in the discussion session. Now, can I request our first speaker, Dr. Hirakawa, he will talk on role of IVUS HD for complete imaging. We know that imaging is a tremendous look for a complex PCI, especially the calcified lesion. Can I request Dr. Hiramo?
Yes.
Okay, thank you very much.
Okay. Okay. Good evening, everyone. Thank you for having me for this Nobel style conference in Bangladesh. It's my great honor to take part in this meeting. So today I'm talking about the role of IVUS HD for complete imaging. So before starting my talk, so why do we need IVUS? Because there is a limitation of angiography. Angio is just a luminography. So if you think about check this eccentric region and you see the angio from this angle, you get only 20% stenosis, whereas you get 60% stenosis from that angle. So for optimal angiographic interpretation of a lesion, you need at least 2 or 3 angiographic views. Actually, the proper vessel sizing is very important. You need to understand the limitation of various vessel sizing technique. So assume that an actual vessel size is 3 millimeter, and OCT is most accurate. The IVUS is the second accurate, and actually IVUS is just a little bit overestimates, but I think it's an acceptable range. And QCA is always in underestimate. And if you don't use any intra-coronary imaging, just you're doing visual estimation, you can go either under or overestimation with huge inter or intra-observer variability. So the margin of error is very high if you don't use intra-coronary imaging. Actually, the meta-analysis of 11 drug-eluting stents studies has already shown that the IVUS guidance drug-eluting stent implantation was associated with the reduction of death, MAID, and stent thrombosis. So in other words, if you use an IVUS, you can get better outcomes, and you can reduce the hard endpoint. And but just using IVUS is not enough. So if you don't get optimal result by IVUS guidance PCI, actually the TVF rate is not good. Actually, this is the data from Ultimate study. As you can see, the patient who met the optimal criteria had a lower rate of TVF at 12 months compared to that in patient who had a suboptimal PCI procedure. So how to get optimal result in using IVUS? So we need a novel IVUS system that has better image quality. Now the Boston Scientific has a new IVUS system, which is OptiCross HD. In this system, they use 60 megahertz. So here, we need to know about the importance of frequency on image quality. So if you use the high frequency, the image quality becomes better, but theoretically, you cannot see far. So it means a high resolution, but short reaching depth. But if you use low frequency, like 20 mega or 30 megahertz, you can see it far. You can observe even large vessel, but image quality is not good. So OptiCross HD system uses higher frequency, which is 60 megahertz, than the former system. It means that the new system has better resolution, but theoretically it may lose reaching depth. However, they developed novel transducer that has wide band technology. So this new composite transducer reduces the ultrasound energy loss by concentrating the energy to forward. So as a result, this system can generate more wider band ultrasound wave that offer the higher image quality without losing penetration depth. So it's like HD IVUS can balance both depth and resolution. So let's move to the brief review of IVUS guidance. So what can we see by IVUS? These are very basic things. So actually, IVUS image of coronary artery is like this. Usually, you can identify 3 layers, right? This is intima. So this black boundary is media. And outside the media, it's an adventitia. So very basic thing. And actually, you can also get plaque characterization by IVUS. So this is almost normal looking vessels, soft plaque, fibrous plaque, hematoma, calcified plaque, attenuated plaque. Unfortunately, today, I don't have enough time to talk about these fundamental issues, so I'll skip the details. But to understand the morphology is a key to make best PCI strategy. So let's move on the IVUS image orientation and landmark. As you know, it's the first step to understand the anatomy. So LAD is the most important vessel, I believe. So let's think about the LAD. So for IVUS image, it's like you are standing at the entrance of LMT to watching to the distal portion.
Okay, take it. No problem. No problem. Okay.
Okay, so it's like this. So on the IVUS image, you are standing at the upstream of LMT to watching the distal portion. So assume that your pericardium is 12 o'clock. So it means that your myocardial site is 6 o'clock. So septal branch is usually coming from your 6 o'clock direction. And circumflex and diagonal branch is usually coming from 90 or 120 degrees, counterclockwise clockwise rotation. So the left side. So this is a basic thing. Actually, this is another example of IVUS orientation. So in this view, the pericardium is here. So it means that you are standing like this angle. So septal branch is coming from your leg, which is around 3 or 4 o'clock. And actually, it comes from the 3 to 4 o'clock. And the diagonal branch is usually coming from 19-degree clockwise rotation. So the actual diagonal branch is coming from 7 or 8 o'clock. So actually, the co-registration between angiography and IVUS is very important to make a better strategy. So next, I'm going to show the proof-back of this vessel. So proof-back starting point is here. So in this LAD, you can identify, this is the second septal branch, the first major septal branch, and the diagonal branch, and the circumflex artery. So you will have 4 major branches. So let's identify 4 major branches during this IVUS image. So first branch is the second septal branch, which comes in around 12 o'clock. So first septal is also coming from the similar direction of the second septal branch. So actually, it is coming from almost a similar direction. And the diagonal branch is coming from 90-degree or 120-degree clockwise rotation, so which is around here. And also circumflex is coming from the similar direction as the diagonal branch. So this is a circumflex artery. So this is a basic concept of IVUS orientation. So the next, how to do IVUS-guided PCI. So this is a minimal IVUS measurement for determining stent size. So assume that you are treating this kind of vessel. So proximal is here, the distal is right side. So first thing is to find ideal proximal and distal landing sites where you would put your stent edges. We call it the reference site. The second thing is measure lumen diameter for selecting stent size in both reference site. And lastly, measure the length between the sites. So that's it, very simple. So presenting IVUS assessment for decision of reference segment, 40% of plaque burden area. 40% is like this image. And the stent diameter should be calculated according to lumen diameter of distal reference. Actually, the ratio of 0.8 to media diameter, or 1:1 to lumen diameter. And the stent landing zone should have less than 50% of plaque burden. So try to find less plaque burden area. And actually, the post-intervention IVUS is also important. Actually, to assess the endpoint of the procedure, the key factors are following. You can identify the stent expansion. If you see the under expansion, you need to correct this under expansion. You can also check the stent apposition. If you see huge malapposition, you need to correct that. Otherwise, you may have stent thrombosis later. And also, you need to check the stent edges. If you see a huge dissection or residual plaque burden, you should do additional stent implantation, right? So these things are very important. Actually, post-IVUS evaluation is very important. So on left side panel, this is a 3.5 millimeter stent was placed, and after that we checked IVUS. Although the angio shows very good result, but if you compare with the vessel size, this stent is really underexpanded. So we did a post-dilatation by a 4 millimeter balloon, and the minimal stent area became 7.2 to 10.4. So IVUS is really helping for the procedure. So next, I'm going to show you the IVUS. So can you find something wrong at this stent proximal edge? Yeah, here. Actually, the vessel is like this. The lumen is around here, but the stent struts are like this. So it's a really huge stent malposition. In this case, angio looks good again, but so if we don't use an IVUS, we didn't recognize this huge malposition. Of course, this huge malposition was corrected by a post-dilatation. So next one is a little bit tricky. This is a stent distal edge evaluation. If you see this, 4 o'clock, actually the intima is disrupted like this, and huge dissection was seen. This is a stent edge dissection. Actually, this dissection reaching to the media. So I think it's better to do the bailout stenting if you see this kind of deep dissection. So lastly, I'm gonna share my case from my catalog. So the target region is the proximal LAD. So in this situation, crossover stenting may need it. So in this procedure, we need to identify the landmarks. So this patient underwent the stent implantation 1 year ago of previously implanted stent, and the next landmark is septal branch, and this is a circumflex artery, and maybe around here is the ideal proximal landing zone in LMT. So let's identify landmarks. So this is a proximal edge, and actually you see the septal branch is coming, and this is a region, and the circumflex artery is coming from 12 o'clock. This is a guide wire from circumflex artery, and here's a proximal landing zone in LMT. So according to the IVUS measurement, we selected Zion's share. Sorry, this is I know this is a Boston Scientific session, but for some reason I selected another company's stent. But 3.5 by 23 millimeter stent was placed like this. And proximal portion, actually LMT has a huge vessel diameter, so we did pot using, I think it's a 4.5 balloon. And they recrossed the guide wire from the LMT to circumflex artery. So after recrossing the wire, you need to confirm that your recrossing wire is running right route. Otherwise, you will have trouble. So this is a real IVUS of this procedure. Circumflex is coming from 7 o'clock. So this is a wire from circumflex artery. So this wire is inside of the stent strut. So sometimes your wire may running through the outside of the stent strut to inside and then side branch. So if you have this situation but you didn't aware this situation and try to open up the side branch ostium, you may crash your stent at proximal LMT. So this is another example. So in this is a bad case. So huge malposition, and these are stent struts. So this is a stent, and this is a guide wire. This guide wire exists outside of the malposed stent. So if you are aware of this kind of wrong guide wire route, you need to correct that. Anyway, so this case, because we already confirmed that our guide wire to circumflex was running right route, so we dilate the side branch ostium using a short balloon like this. And after that, we did repot using the big balloon. And this is a IVUS after repot procedure. So final IVUS, you need to confirm the stent alignment at the bifurcation site, and you need to confirm that no huge stent malposition nor edge dissection. Okay, so let's check the IVUS. So this is a circumflex artery ostium. So stent is widely open, and the proximal portion, stent is well opposed. So this is the final angio. Although this, LMT to LAD has, huge, discrepancy in terms of diameter, but we get in a good position in both segment. So, ladies and gentlemen, let me conclude my presentation today. The novel 60 MHz HD IVUS can achieve higher resolution compared to the 40 MHz IVUS without losing deep penetration. So now all the operators can understand vessel morphology very easily and very clearly by using the HD IVUS. To utilize this novel IVUS properly and get optimal result is a key for successful PCI. Thank you so much for your kind attention.
Hello, Professor Abdul Rahman is here. Okay, thank you for a nice presentation and especially for role of IVUS and HD. Nice representation. Any our panelist, can you say something? Our panelist.
Can I add a comment?
Yes, yes.
Yes, I have seen that our presenter presented papers very nicely, but I have a question here. You, in your presentation, you have shown that the OCT gives the actual diameter of the vessel.
Yeah.
And IVUS gives overestimation and QC gives the underestimation. So in this respect, I like to add a question to you. If I give a intracoronary nitrates and I examined after intracoronary nitrates, what will be the actual result by the QC? Is it true or it is false? It gives a false result.
Oh, thank you. Thank you for your question. Actually, before taking the IVUS image, you need to inject nitrates, right? And if you take an angio, actually the disease vessel, it's good to inject nitrates as well. So I think that the result is same with or without nitrates. Okay. So IVUS is usually maybe 8 or 9% overestimate. So if you select a stent size, you need to be take into consideration of this fact. Yeah.
Any other panelist? Yes. Dr. Pradeep, you want to say something? Yes. Okay, please.
Yes. Thank you very much for your nice deliveration. I have some query, especially in distal left main standing. If I have a lesion in the proximal LAD and there is some lesion in the distal part of the left main, suppose it is 2 to 4 millimeter, what I should do? Because if should I hang 1 or 2 millimeter in the left main, or I will cover the more proximal left main, because our aim to post dilate the left main only the stent area, not in the normal area. Have you got my question?
Yeah, thank you. Thank you for your good question. For proximal, you mean distal LMT, right? So
yes,
then you need to, the space for pot. That usually, you treat the LMT by pot, right? So
yeah.
Minimal, balloon length is, I think, 6 millimeter, right?
Yeah.
So at least, actually the side of the entrance of circumflex artery is like 2 or 3, right?
Yeah.
So your stent should be maybe, let's say, 4 or 5 millimeter proximal to the bifurcation.
Yeah. But if the lesion only 2 millimeter, maximum lesion area in proximal LAD, and it enter into the 2 millimeter into the left main, what I will do?
I think you need to take consideration of the length of circumflex artery, right? Assume that it's 3 and proximal portion is 2, and you need 1 or 2 millimeter margin
inside the left main.
Yeah, I think you need to take some margin, like 1 or 2 millimeter, right? So
can I put this, guys?
Yes, Pradeep.
Pradeep, thank you. Professor Abdul Rahman already answered.
Now, Pradeep, can I add something to this question?
Yes, sir.
Because your question
about the IVUS.
You have a very important question. Suppose that your lesion is only 2 millimeter beyond the LAD ostium.
No. It's proximal LAD. Proximal LAD, and it is protruded inside the left main 2 millimeter.
That's right. That I'm telling them.
Yes,
that I'm telling them. Your lesion in the LAD and the lesion in the LAD and protruded in left main beyond the ostium only 2 millimeter.
Yes.
But you have to think about that. You have to dilate the proximal portion, proximal port. So you must cover the LAD as far as possible where you can make a proximal port. Suppose your left main is an 8 millimeter, then you have your balloon size, lowest balloon size is about 6 millimeter. So you have to protrude the stent in the left main at least 4 millimeter, 5 millimeters, so that you can properly make a proper port. There is no harm for that. There is no harm for that.
Yes, I understand.
Sir, thank you.
But if you make an port by the bigger balloon, then maybe the plaque shifting, that might create a problem. So yes, I think so. That's a good, valid question. That's a good question. I think so.
Good question.
Another question: we are getting the 50% of our IVUS cases is negative remodeling. What is your thinking about the stent sizing, the negative relation of negative remodeling?
Thank you. Actually, negative remodeling it's a very dangerous situation, right? If you identify this lesion is a negative remodeling, right? I think we recommend to dilate maybe a quarter or half size, down balloon, right? And after that, inject the nitrates and check the IVUS again. And even after the pre-dilatation and nitrates, you still have a severe negative remodeling, right? You need to pay close attention to avoid coronary perforation. So in this situation, you must select a little bit smaller stent.
Yes, understand. My last question. Last question.
Okay.
What is your team? Because we are stented, all of stent.
Just unmute yourself, please. Pradeep, you are muted. Probably you are muted.
Do you have any conception? Because in IVUS era there is a term, the step up and step down. Usually during the stented segment, the proximal end should be step up and distal end should be stepped down, because we are stenting in a resting coronary artery. Because when the patient go to the exercise, if we fix the lesion dia, then the patient may suffering for chest pain even there is no stenosis. What is the conception about that? Step up and step down.
You are talking about tapered vessel, right? Tapered vessel.
No. Coronary vessel is not tapered, because the thing is, when the stented segment, any stented segment, the proximal end should be higher, and distal end also is a step up, and distal end will be step down. The stented segment should look better dia than the normal reference segment.
I think if you do overstretch is not good, I think. So
because now everybody is saying that the bigger is better.
Yeah, right.
Yeah.
But too big is not, better.
Yeah,
so,
not too big, but big.
I think try to select the as the same size as the distal reference, and then correct using a short balloon to adjust the proximal portion. What is
the distal reference?
A lot of session actually, Dr.
Media or external elastic lamina to external elastic lamina.
Actually, for distal size selection, if you use the lumen diameter, you should use the 1-to-1 ratio. So if your distal lumen diameter is, let's say, 3.2, you should select 3.25 stent. I think you use media size, right? Media to media. You should select 0.8 ratio.
0.8.
Right.
0.8
nowadays it is same external elastic lamina to get the biggest size stent.
Okay, thank you very much. I think so due to shortage of time, Jaman, can you call your second speaker?
Okay, thank you, sir. Professor Abdul Rahman. Actually, with the permission of the chairs, and already our Professor Abdul Rahman told me, please, I request the next speaker, topic is high bleeding risks and complex PCI, how I assess and optimize outcome. Dr. Nikhil Pachuri, please proceed, Dr. Nikhil Pachuri.
But all the speakers are requested to keep on time, because our talk time is 12 minutes and the question session is 3 minutes. So we have to finish each of the talk within 15 minutes. That is instruction by the organizer.
Thank you. Good evening, friends. I'm going to talk about patients with high bleeding risk undergoing angioplasty. And I'm going to talk about precision angioplasty in these patients and how to achieve it using imaging guidance, which is optimized using imaging as well. So I'm going to use one of my patients and then inform you how to create a strategy based on the literature and the data available. So my patient is a 36-year-old gentleman who had chest pain a month ago. Unfortunately, started having chest pain on exertion and had chest pain on dialysis as well, with a past history of GI bleed 6 months ago. His ECG demonstrated biphasic T-wave inversion in the anterior leads consistent with LAD syndrome. His hemoglobin was 8, with a creatinine of 3.8 on hemodialysis, and he was undergoing transplant workup. This was his coronary angiogram, which showed a subtotally or recently occluded LAD. Now, I need to create a strategy for this patient, but I know this patient is on hemodialysis. He is being worked up for a transplant. He is anemic. He has a past history of GI bleed. That's why I'm worried about this patient with a high risk of bleeding post-PCI. So am I going to discontinue his DAPT earlier? And how do we do that? So let's have a look at the literature very quickly to create a strategy for my patient. So a white paper was published last year in Circulation in 2019, defining high bleeding risk in patients undergoing PCI. This paper informed us that there are various factors associated with HBR during PCI, including age, renal and liver disease, active cancer, anemia, low platelet count, previous history of hemorrhagic stroke, bleeding diathesis, prior bleeding, need for oral anticoagulation, need for NSAID and steroids, and a planned surgery. But did you know that some of these factors constitute a major risk factor and some constitute minor risk factors? And for the patients to qualify as a high bleeding risk, you need to satisfy one major criteria or two minor criteria. So our patient clearly falls into this category of high bleeding risk with end-stage renal disease on hemodialysis, with a past history of GI bleed, anemia, and planned surgery. So what do we do? Let's have a look at the literature again. So far, we have achieved significant reductions in thrombotic complications, specifically stent thrombosis, after PCIs. But bleeding remains one of the most common complications after PCI, with up to 6% of patients experiencing a major bleeding event. Unfortunately, these patients who bleed have a significant association between bleeding and increased risk of death and myocardial infarction. So clinically relevant bleeding occurs in up to 6% of patients, but more importantly, up to 4.8% patients are hospitalized post-PCI, with most common source of bleeding being GI tract. Majority of the bleeding occurs within 30 days post-discharge, but this post-discharge bleeding-related hospitalization after PCI is associated with subsequent death and MI with a hazard ratio of 3. That means if you bleed post-PCI and are hospitalized, your risk of death or MI is 3 times as compared to those who don't. This highest risk of death or MI occurs in first 60 days after bleeding-related hospitalization. So how common are HBR patients in routine practice? Well, 40% of PCI population meet criteria for HBR and are at high risk of bleeding at 1 year. How do we know that? Well, we know this from Burn PCI registry, which treated more than 12,000 patients between 2009 and 2016, with a total of 40% identified as HBR. More importantly, at 1 year, these HBR patients, 40% of them, had increased risk of primary endpoint of BARC3 or 5 bleeding, 6.4% versus 1.9%, and a composite endpoint that included cardiac death, target vessel MI, and TLR at 12.5% as opposed to 6.1%. Remember, our patient falls in this category with a high risk of bleeding, death, and MI. Let's have a look at the trials then. What did the trials do? Well, LEGUS-3 trial involved short DAPT with Synergy, Onyx-1, senior again with Synergy. All these, the commonest criteria were age more than 75, need for oral anticoagulation, renal failure, anemia, hospital for bleeding, actionable bleed, and thrombocytopenia. Majority of these trials gave DAPT for 1 to 3 months. Well, when we look at the second generation tests, there were more than 14 trials with short DAPT of 3 months or less. Specifically, we're talking about Senior with 1 month, Evolve, Synergy, 3 months, Science and Onyx-1 with 1 month. What do the guidance say to us? Well, the guidance tells us that if you have an HBR patient who is undergoing PCI and is stable, then 1 month DAPT has class 2B C indication, and a 3-month DAPT has a slightly better class 2A B indication. But if the patient is ACS and HBR, then the recommendation is 6 months of DAPT with class 2A B indication. We have another tool in our armamentarium, and we did use that tool of the Science DAPT score. And when we calculated this score for our patient, it came to be 70. That means high risk of bleeding with a risk of major bleed of more than 4%. Remember, if risk of bleeding more than 4%, then there is a high risk of death and MI. What do the trials say? Which stent do I use? Well, Look at this evolved short DAPT trial with Synergy, using more than 2,000 stents of 2,000 patients of HBR patients, and analysis period of 3 to 15 months with 3 months DAPT. There is no more increased risk of stent thrombosis, and there is no more increased risk of death or MI, despite the fact that DAPT were discontinued after 3 months. Well, we get some knowledge from it. Well, when we look at Onyx 1 global study, they discontinued DAPT after 1 month, but unfortunately, the stent thrombosis rate was 1.5%, which according to me is unacceptable. There was a cardiac death of MR 17.3% in this trial. There's a TLF of 18% and an MR 13.5% and cardiac death of 4.6%, which to me is unacceptable. Okay, look at senior trial. 1 month DAPT, 1-to-1 against bare metal stent, Synergy against bare metal stent of 1,200 patients, and 1 or 6 month DAPT with no more increased stent thrombosis or death. Well, we also have Synergy stent where chronic stable angina patients were taken and they were given DAPT only before PCR, and from day 2, no more DAPT. And look at the rate of stent thrombosis. None increased. So what we have with us, actually 3 trials, ASSET with no DAPT, senior with 1 month DAPT, and evolved short DAPT with 3 months DAPT, and no more increased risk of stent thrombosis here, which actually satisfies us. So we opened up that LAD, and then we did an OCT pullback on this to precisely know about length of the lesion, proximal landing zone, distal landing zone, and diameter of the stent. How did we do that? Well, that's where we thought is the best portion for EL to EL diameter at distal edge. This is what we were going to do according to the lumen profile. We thought that's where here we will plant our proximal edge of the stent, but we had to increase the length here. As you see, there's an orange glow around throughout circumferentially in every picture except this. From 2 to 6 p.m. in this picture, there's a darkness behind which denotes what we call thin cap fibroatheroma of less than 65 microns, whereas the vasora in the adventitia, there's macrophage infiltration, there is new vessels in the intima, and cholesterol crystals, hallmark of what we call vulnerable plaque. If we would have put our proximal stent edge here, the patient would have certainly come back with either stent thrombosis or restenosis. So we chose the stent length and diameter from what the data we achieved, and this is what we achieved. In any OCT, we will see an angiogram, which is co-registered with the OCT, a lumen profile, and what we have achieved after stenting. So what did we do with that? We actually looked at proximal edge and distal edge. There was no dissection. Then we specifically look for malposition and under expansion. This box gives you about the under expansion there is not. And look at the residual diameter stenosis, 3.3% only. That's minimal lumen area, and that's the position where it is. Totally acceptable. And the red mark, nowhere except this. So if we think that this is malposition, well, do a 3D. And you see at that position, it's not malposition, but actually is the side branch there. So having satisfied ourselves with fully deployed stent, this is the angiographic view, which was very satisfying. Okay, how did we achieve that? Pre-PCI, we looked at morphology, we found Techniqu, that's why we checked appropriate length and an appropriate diameter, MLD. And post-PCI, we looked at dissection, there was none, there was no malposition, and there was no under expansion max. So this is the new algorithm on OCT called MLD max. So why I chose Synergy stent? Well, this is an ultra-thin struts, there's a biodegradable polymer, there's a synchronous drug elution and polymer absorption, which leads to what we call early healing, freedom from long-term polymer exposure. And this is the first test to get FDA approval for short DAPT and you saw the 3 trials. Well, what is early healing? Early healing, we find out that all the stent struts are covered by intima, number 1. And number 2, this neointima actually is homogeneous rather than heterogeneous. So this OCT study has actually been shown that the synergy stent is good for healing the vessel. So this is an observational cohort study of consecutive patients from the Pan-London registry, which is 2015 or before, with IVUS use of 12.1%, OCT of 1.3%, and restful angiography. And both IVUS and OCT save life. And there's the same thing in STOP DAPT 2 trial. All patients underwent PCI and short DAPT in Japan, and all of them were IVUS guided. And that actually prevented the stent thrombosis in that trial as well. So in summary, this young man had ACS with HBR on the basis of ESRD, history of GR bleed, anemia, and planned surgery. We utilize knowledge from published trials of PCI and HBR patients to make decisions. We utilize imaging guidance to achieve optimal results to minimize ischemic events. Most importantly, what is the FDA perspective on DAPT labeling? Shorter DAPT duration may impact the safety and effectiveness profile of an approved stent, and therefore, a change in recommended DAPT duration in the stent labeling requires supporting clinical data specific to that stent. And Synergy being the first FDA approved stent for shorter DAPT, and that cannot be extrapolated to any other stent. Thank you. I hope I stuck to my 12 minutes.
Thank you.
Congratulations, you have finished. So we have 3 minutes. Jaman, can you ask the question to the panelist, or is there a comment from the panelist?
Yes, sir.
Or any chairperson?
May I ask a question, sir?
Sure.
We have seen there are lots of risk factors for high risk bleeding risk. But my question is, which one we considered more serious issue regarding the, in terms of 2, that is the anemia or thrombocytopenia, which one is more aggressively responsible for the high risk bleeding? Or should we consider both are same?
Thank you for a very important question you have raised. I have not shown you a slide where I wanted to show some further issues, and this was one of the issues. That if we look at various risk factors for high bleeding risk, do we have different weightage given to different risk factors which you have raised? We at the moment do not have the answer to that which risk factor has to be given more weight as compared to other which you have raised, number one. Number 2 issue is which antiplatelet to discontinue after 1 month or 3 months. If you're going to use aspirin and clopidogrel or aspirin or ticagrelor, after 1 or 3 months, which do you discontinue? Well, the wisdom today, an acceptable approach today is that the drug responsible for GI bleed is aspirin, and therefore you discontinue aspirin.
Maybe technical internet, maybe. Hello. So can I proceed the? Yeah, already.
Yeah, can you hear me?
Okay.
Yes, now hearing.
So at the moment, we do not have that weightage given to different risk factors in HBR. That's the answer.
So you will stop the aspirin and continue the clopidogrel or ticagrelor. That's right.
At the moment, that's what we do.
Or it is better to continue ticagrelor.
Yes, we actually don't use clopidogrel nowadays. We only use aspirin and ticagrelor, and for HBR patients, we discontinue aspirin and continue ticagrelor.
Yeah, that's right.
Yes.
So
yes, Pancholi, in 2020, there is ESC guideline shows that increased role of prasugrel. If in a patient, the stent is deployed, then prasugrel should be must after the aspirin. What is your recommendation? What is your remark?
Well,
ESC guideline in 2020 shows the importance of the prasugrel with aspirin other than clopidogrel and ticagrel. What is your comment?
Yes. The accepted norm throughout the world, or at least in Europe and America, is a DAPT of aspirin with ticagrelor. We were using prasugrel earlier for only patients who came with ST elevation MI. And you have to be very careful not to give prasugrel to patients over the age of 75, number one. Number two, you can't give prasugrel to patients who have a weight of less than 60 kg. And number three, you can't give prasugrel to patients who had a previous history of stroke. But since the outcome data of ticagrelor is available to us, we only use aspirin and ticagrelor as DAPT in PCR. And that's what the commonest use throughout the world is.
Okay, thank you very much. I think so. Thank you very much. Thank you. And this is a very elegant discussion. Now we can. Aman, can you call the third speaker?
Thank you, Professor Abdul Rahman. Now I request Dr. N.A. Mohammed. His topic is calcified lesion, interpretation, basic and beyond. This is very, very important issue our daily life. I request Professor Dr. N.A. Mohammed.
Am I audible, visible?
Yes, sir.
Okay, thank you very much. And indeed, it's a great pleasure for me to be part of this virtual summit 2020 organized by BSCI, and welcome you all, both the home and abroad participant. I was asked to talk about the calcification intervention. So I choose this talk like calcification intervention, basic and beyond. My talk will contain the basic of some form of calcification, and then partly how to detect it, and its impact on coronary artery disease, and modalities of treatment available for the management of calcific arteries intervention, and finally one case presentation. Coronary calcification is a marker of advanced atherosclerosis and is correlated with complex coronary artery disease, including long lesion, chronic total occlusion, bifurcation lesion, etc. And PCI of calcific lesion is associated with incomplete lesion preparation so as to produce stent under expansion, malapposition, and is a worst predictor for clinical immediately by edge dissection, stent thrombosis, etc. As well as for long run, it also is responsible for high mortality, MACE, TVF, and TLR. If you consider the heavy calcific stenosis, it has got a very hard plaque, irregular lesion surface, difficult to dilate adequately, and may contribute to the failure of stent delivery or incomplete stent expansion. There are various reasons for the lesion preparation that makes it difficult. The calcium often impaired balloon advancement, prevent adequate balloon dilatation, sometimes as difficult to stent advancement, even advanced difficult to dilate, delivery the stent. And also, if you do too much of manipulation, may damage the stent starts and also polymer coating. And ultimately, what happened there under expansion and malapposition. So the lesion preparation of calcific lesion before stenting is a paramount important to achieve the optimum result. If you think about what is calcification of coronary artery, it means that the calcium are deposited in the coronary arterial wall or atherosclerotic plaque that can be identified by X-ray, CT angio, fluoroscopy, cine angiogram, IVUS, or OCT. And if you consider the morbid anatomical position of the calcium, it can be in the deep calcification distributed in the deeper layer of plaque and the middle layer up to the external meeting membrane. That means that medio-adventitial border or close to the adventitia. The superficial calcium is distributed in the subintimal space up to the inner limiting membrane and mostly within the atherosclerotic plaque, means that it is close to the intimal luminal interference. And the mixed is a combination of these two along the vessel wall. There are certain factors actually associated with the high calcification of coronary artery, mostly the advances, hypertension, dyslipidemia, diabetes mellitus, chronic kidney disease, patient on dialysis, and hyperthyroidism, parathyroidism, and any patient with hypercalcemia or hyperphosphatemia. If you have calcium, what is its impact on coronary artery disease? You see, the microcalcification in the fibrous cap might promote cavitation-induced plaque rupture. Additionally, the calcific nodule might disrupt the plaque, superficial fibrous plaque that leads to thrombus formation and acute coronary syndrome. And recurrent plaque rupture and hemorrhage within the plaque subsequently healing and hemorrhage that develops obstructive fibrocalcific lesion and are frequently found in patients with stable coronary artery disease. We can detect it by CT angiogram because a CT scoring of calcium is a good predictor for coronary artery disease. Although if the calcium score is too high, it loses sensitivity in terms of identifying the obstructive coronary artery disease, but also gains a specificity about the prediction of coronary artery disease. If somebody has got a score less than 0 or no calcium, means that almost it's a negative predictive value is 100%. But if anybody having a score more than 0, it means that there is a possibility of underlying atherosclerosis. And if somebody has got score 100 to 400, he need a prompt risk factor modification, and further diagnostic evaluation is necessary to identify coronary artery disease. One interesting finding is that asymptomatic patient without traditional risk factor but with a score of 400 might have a worse prognosis compared to the person having no calcification but 3 risk factors. Similarly, the fluoroscopy and angiogram also can identify and graded calcium in 4 graded. No calcification, class 1. Class 2 is the mild calcification, means that light or blood beating calcification, seen only the beating heart. Moderate is the clear calcification only shown during the cardiac cycle before the contrast injection, and severe calcification usually shown the clear shadow of calcium without even the motion of the heart, and is visible on the both sides of the artery as a double track. IVUS can also have got a grading of calcification from 0 to 4. 0 means no, and grade 1 is on the basis of the circumference of the calcium as an arc. Up to 90 is grade 1, and up to 360 is grade 4, and in between grade 1 and 2. Interesting finding is that the IVUS can detect about 82% patient coronary calcification compared to other OCT. This has been studied on 440 patients. Like this, the acoustic window opposite the calcium. One is the mild, less than 90s, and other is the more than 90, almost close to 360 severe calcification. The other modalities of calcium identification is the OCT, because it's a high resolution imaging, and it can detect calcium as a low intensity, low attenuation area with sharp border. And moreover, as the light carries calcium, so it can also identify the thickness of the calcium and also volume of the calcium, like this. And on the basis of this, one can predict the outcome of PCI if somebody has got calcium more than 180 degree, length more than 5 millimeter, thickness more than 0.5 millimeter. It has got a poor outcome compared to those who have got not of this type of scoring. So in patient handling with a calcific lesion, you'll have to have a good number in your hand to handle this patient while going to the cath lab. Like but in the very beginning, you should have a very good backup support like XB catheter or a VU 6 or 7 French. You may need sometimes the guide extension catheter like Godzilla or Guideliner. Hydrophilic polymer wire is better to track because have less friction with the calcium. And sometimes you need a double wire, body wire, to get an extra support. And also it can help to cut the calcium, use a non-compliant balloon with a 2 wire inside. The pre-dilatation balloon of different type, including semi-compliant, non-compliant, short balloon, angioscalp, scoreflex, cutting balloon, even on the high pressure opium balloon is also important armamentum for handling the balloon category of devices in coronary calcification. There are other like rotablation and orbital atherectomy, and latest the shockwave intravascular lithotripsy. It's a good device that can be used to tackle severe calcific lesion. And above all, the stent should be having very good radial strength, and if not possible to track the bigger stent, you can use the short or small stent to cover the lesion. If you consider the balloons dilatation, commonly NC balloon available it can go up to 20 atmosphere, and sometimes it may go up to 24 atmosphere. Cutting balloon has got a blade on either side of the balloon. Score balloon like angioscalp or scoreflex having extra wire along the balloon. And sometimes you use the 2 wire, inflate the short 8 to 10 millimeter NC balloon, about 0.5 millimeter smaller size than the reference vessel diameter, and inflate for 20 atmosphere for more than 20 seconds. This is the picture of you all know. This is the very unique super high pressure balloon with twin layer technology, allowing the minimal balloon expansion after dilatation. Nominal pressure is 10 atmosphere. It can go up to rated burst pressure 35, but sometimes it can be reached up to 55 atmosphere. One interesting finding is that the opium balloon can successfully treat more than 90% of undilatable lesion compared to the conventional non-compliant balloon. Also, rupture rate is very less than 1%, and it is also compatible with regular wire what we are used for normal PCI. And it is a unique character of this that if it expands fully, it can eliminate the dog bone effect, and also they reduce the chances of edge dissection as it happened in a conventional non-compliant balloon. Remember, while using opium balloon, it's better to use with the extra support wire like All-Star or Grand Slam, and pre-dilate with a 0.5 meter smaller size balloon from the reference vessel diameter, and after that a post-dilatation with 1:1 ratio. And you should have a inflation device that has got the capacity to reach up to 55 atmosphere, and it is preferable to increase the pressure gradually once it reaches to 20 atmosphere. The one interesting mechanism for this hard plaque crack is the crisp phenomena. This is a tendency of a solid materials to move slowly or deform permanently under the influence of persistent mechanical stress. Actually, this principle been used while dilating the calcific lesion with an NC balloon. The calcium lesion is produce a distortion force that are capable of expanding a hard calcific lesion. The rotablation is one of the oldest device used to debulk and modify the atherosclerotic plaque, and an adjunctive to study of in fibrocalcific lesion. The bar is kept in the proximal. Rotablation can be started with a short bar run of less than 20 seconds, and rotational speed may be 135,000 to 180,000 RPM. The bars to vessel ratio is usually 0.6 to 1 to avoid dissolution speed. Similar devices, orbital atherectomy, it's a diamond-backed micro crown device, usually elliptically moved, a single size, eccentrically mounted a crown to create a centrifugal force that differentially sending the hard and component of the plaque and sparing the soft part. It has got only one size, 1.25 orbital atherectomy catheter for low. It can go up to it can be used in the vessel 2.5 to 4 millimeter. The low speed is 80,000 small vessel and 120,000 for the bigger vessel. And orbital atherectomy can cut deeper and longer calcific plaque and modify plaque better than rotational atherectomy. Consequently, the better stent expansion and opposition. So another variety is the latest promising the modalities of handling the calcific lesion is the intravascular coronary lithotripsy. It is a pulsatile mechanical energy is used selectively the amorphous calcium, sparing the soft tissue. It is more effective in concentric calcification and is user friendly because it is similar like a normal angioplasty balloon and has got a little learning curve. And procedure complex is also very low. But surprisingly, it can be only single use device because it has got 3 miniature lithotripsy emitter distributed along the length of the balloon, and it is before placement in the lesion. So there are some method actually you can use for the mild to moderate calcification. We call it modified balloon technique. You can use 2 wire in a targeted vessel, use a short NC balloon 0.5 millimeter shorter than the reference vessel, and raise the pressure slowly until the lesion dilate fully up to the rated burst pressure as evident by balloon contour seen in different projection to see the dog bone effect. Do prolonged inflation time with NC balloon. The procedure can be done repeatedly until the lesion crack. And once the lesion crack, then your dilate should be done with another NC balloon and with a 1:1 ratio before implanting the stent. Now I'm going to show one procedure that has been done by modified balloon technique. The patient with calcified lesion in the mid and RC, distal RCA, you're seeing the double track in the distal part more severe than the middle part. So after placing a regular wire, you use score flakes that can go up to 15 atmosphere rated burst pressure, and after that, after dilatation, it shows little dog bone effect in the distal part, which was further increased in the abolish that one, but still it needs few more things to do. After that, I took 2 wire to use a bigger size balloon. Initially it shows still there is a dog bone effect because it was a bigger size balloon, and if you raise the pressure and keep it for at least 20 seconds, the dog bone effect has gone, and the vessel the balloon in contour is like normal, and it was sequentially dilated because there was also proximal lesion. And after the balloon looks much better, there is not much of dissection or indentation of the vessel. And then there's the 2 synergy stent was used, the distally one and covering the proximal one with another stent. So this was the post dilatation with the 3.5 balloon, and this was the final result after stent implantation in a civilian. This is the lateral view, and this is the LO view. I have used the IVUS to both pre and post, but unfortunately I cannot show it because of the technical fault that the image was not been retrieved from the IVUS console. So I'm sorry for that. So in conclusion, in dealing with the calcific lesion, I can say that the problem of heavily calcified coronary lesion increase in future because of the ongoing increasing the aging population, number of diabetic and chronic renal failure patients. Calcific lesion should be prepared well and don't implant any stent before fully dilated the calcific segment. IVUS and OCT should be used to assess the extent of the calcium, and there is a high procedural success and low peri-procedural complication if you use combinedly the NC balloon, scoring balloon, cutting, rotational atherectomy, orbital atherectomy, and recently OPN balloon and intravascular lithotripsy are a good armamentarium to deal with severe calcific coronary artery disease. And remember that drug-eluting stent and more effective antiplatelet agent decreases chances of stent thrombosis and stent restenosis. Thank you very much.
Thank you, Dr. Jaman, for your brilliant presentation. I think so.
Am
So
I
there is
in,
no doubt
am I in
about
time?
that. All of the modalities we have. So, is there any panelist? Do you have any comment, or chairperson? Do you have any comment or question?
Sir, I can say something, sir.
Yes, you can say, but you can say only
Sir,
one. Then
one, sir, of course.
Okay.
Sir, Mohan sir, I have a not question, query, sir. If the calcified lesion has the thickness more than 0.5 millimeter, that means the calcium is disseated, then rotablation or orbital atherectomy or lithoplasty balloon, which device will be the better for treating this type of lesions?
Actually, if you go to the algorithm,
yes,
the rotablation and orbital atherectomy, is better in terms of cutting the deeper calcium compared to rotational atherectomy. But if it is in the media, none of this device can remove it.
Yes,
only
sir.
you can use
Litho
either
plastic
opium balloon
or
either opium balloon or lithotripsy.
Lithotripsy.
These two devices can completely open up the vessel.
Okay, thank you, sir.
I have a question to our chairperson and our next speaker, Dr. Samuel K. Matthew, especially two types of modalities actually, balloon-based techniques maybe, or maybe atherectomy. But without imaging, especially for our beginners, how we can assess, especially without imaging, that before calcification is actually the undelivered lesion, any tips and tricks without that center, very few use imaging. So Dr. Samuel Matthew, have you any tips and tricks in this regard? Dr. Samuel Matthew, you are unmuted maybe.
Maybe he will give the comment after his talk.
Okay.
Aman?
Okay.
We will ask him after his talk.
May I ask a question, sir?
Yes. But
Sir,
you have to give you have to go to the floor of the other panelists also.
Yes, sir. There is no question from the other panelists.
Okay.
So I come forward.
Okay, thank you.
Sir, thank you, sir, for excellent presentation. I have a question to you, sir. Sir, if a stent is stacked at the middle of the journey of lesion, just after proper preparations of the calcific lesion, how can you tackling the lesion?
Yes. Before putting a stent, I said that never attempt to place the stent in the calcific lesion unless the lesion is prepared properly. And you can also take it a short run of undilated, undeflated balloon across the lesion after dilatation. Still, there is a chances of stent stuck because of a nodular calcium. That is very notorious because because of the wire bias. It sometimes stuck at the site of calcification. In that case, you have got a lot of options. Like you can use a body wire to align this cell. You can use a guide extension device like Godzilla or Guideliner, but don't manipulate too much. Then there is a chances of stent dislodgement.
So the stent is already stuck.
Stuck.
Yes, sir.
Stent already stuck
at the middle of the
stent.
Yeah,
inside the stent. Stent already stuck inside the calcified coronary segment.
Yes, sir.
Professor Abdul Rahman, can I ask one question to Mohan sir?
No, let me answer the previous one. If you don't inflate the stent, there is a little chance that the stent will stuck within the calcium. Means that you have not prepared the bed well. Otherwise, there should not be any reason to stuck, because the profile of the uninflated stent is much more than the balloon dilated.
No. Moment, Jaman. The question is that whatever the situation, now the stent is stuck in the calcified lesion. What you will do now? You can say that you should prevent it. That's a different issue. But how you can retrieve yourself? That is the main question.
You cannot come out. Is that question?
Yes.
In that case, and you can use some luxury technique, like you can place another wire, and you can make some form of straightening the vessel, and don't think it will be wise to inflate the stent at that place. Anyway, if you do it, there is a chance that the stent will not expand fully. By any way you can, if you cannot retrieve that one, you can use a snare to catch the stent and you can pull it in a mass. There is another option. Or you can place another wire inside, little balloon dilatation at the site of stuck, then you can put. It is almost uninflated stent stuck in the calcium.
That is a difficult situation actually, better to avoid it. And we have to take all the measures. Now, can I request Dr. Samuel Matthews for your presentation, plaque modification in the calcified lesion. I can remember one of the comment from you. Can you remember the story that you have visited many times in NICBD and bringing all the hardware with the help of the Kasim and taking off from the airport, and I was the person who accompanied you, and you take all the accessories in the NICBD. And I said to that, which catheter would you like to take it? You said to me, any catheter give me, I will do that, no problem. 3, 4, 5, you have what you in cath lab. So now my question is that in your presentation, I want to see that we would like to see that any devices is comfortable to you, dealing with any kind of the plaque modification. Let us see the legend professor, Dr. Samuel Matthews. Matthews?
Are you seeing my slide?
Yes, no, yes, already. We are hearing also and already seeing your slide also.
But we are not hearing anything. Raman, are you hearing?
Yeah, I am hearing, please. Dr. Matthews, please.
Yeah, can you hear me?
Yes.
Sound is a little bit low.
Sound is low, please.
Sound is very low.
Increase your volume, please, but we are hearing also. Please. Dr. Matthews? Yes. Your slide in the monitor.
Sir,
please.
you are not audible, sir.
Not here, we are not hearing.
Now from very beginning, his device is very low sound.
I think.
Okay. I'll try my best.
Okay,
Yes,
sir.
sir.
Now audible, sir.
Can you hear me now?
Now we are hearing.
Ask your
No, sir. Not clear, sir.
Not clear.
Sir, we want a very clear voice of you.
Yes.
Okay. Good evening, everybody, and it's a
Little
great
better.
pleasure for me to
A bit better, yes, sir.
address
Little better.
a gathering where all my good friends, Alsur Rahman, Muhammad Zaman, Tulpia.
No, sir.
We are not hearing.
Sir.
Debulking devices are needed for non-yielding lesions, even at high pressure, as now you listen to Muhammad Zaman. Fibrotic lesion, calcific lesions, and all these lesions, we need something more than just balloons. The first concept of debulking came in the 80s from DCA. This is the catheter which was first started. This is a Simpson aggression.
Need sound modification.
Sir.
Ask your audio people.
Yes.
There. I can't increase more.
We can't hear anything. We'd love to hear him.
I don't know what to do. I don't have a mic.
Sir, you need a earphone, sir.
No.
Sir, everybody can use earphone and increase their earphone volume, sir. You use earphone and increase your earphone volume. Sir cannot do anything, sir. As I do.
Will it work?
Mohan sir.
Mobile phone, will somebody?
Matthew sir.
On my mobile. Yeah.
Sir, আপনার মহানুজ্জামান স্যার আপনার বাড়াইতে পারবেন স্যার আপনার ইয়ারফোনের ভলিউমটা বাড়ায় নেন স্যার
আপনার নিজেরটা বাড়ায় নেন নিজেরটা বাড়ায় নেন
ভলিউমটা বাড়ান স্যার ইয়ারফোনের ভলিউম বাড়ায় নেন
না বাড়ালেও লাভ হচ্ছে না আমরা তো বাড়ানো আমি তো শুনছি না
আমরা শুনছি না তো সিজার
ও আচ্ছা আমরা শুনছি
ম্যাডাম from very beginning Professor Mathur sir volume is very low.
Yes.
Here we cannot compromise. We have to listen to him. Actually, we cannot even hear a little bit.
So, madam,
I think if he comes closer to the monitor and talk, then we can hear.
Yeah, maybe that will help if he comes closer to his
device
or laptop.
Very close to the
might work.
phone. Very
Thank you,
close
sir.
to the laptop.
Yes, sir. Now audible, sir. But
now audible, sir. You can carry on.
Little audible, little.
Yes, and not satisfactory.
মাহবুব নিজের সাউন্ডটা বাড়ায় নাও
আমি তোমারটা শুনতে পাচ্ছি তো সবকিছু
নিজেদের কথা তো শুনতে পাচ্ছি ওনারটা শোনা যাচ্ছে না
পরিষ্কার শোনা যাচ্ছে
স্যার আপনার সাউন্ডগুলো বাড়ায় নেন স্যার ইয়ারফোনের সাউন্ডটা বাড়ায় নেন
আমাদেরটা বাড়ানোই আছে শুধু ওই স্যারেরটা শুনি না
আরেকটু বাড়ান মাহবুব ভাই আরেকটু বাড়ান হয়ে যাবে আমার
হাতে যা আছে সব বাড়ান ডোন্ট কম্পেয়ার উইথ
মাহবুব আমরা ম্যাথুজেরটা শুনতে পাচ্ছি
Let him speak. আমি তো বলছি only moderator can talk. Please, moderator should try to negotiate.
Can you hear me now?
Yes, audible, please.
Very low volume, sir.
This is the device which many of you would not have even seen. This is DCA which was used in the 80s. The first atherectomy catheter we used. But this device went out of use because the restenosis rate was very high, 40 to 50%. Used in some cases only in Japan. This is the patient who has got a left main disease, you can see. And this is the IVUS findings. You have got calcification and fibrotic lesion, which was cut using a DCA, and post-cutting, you can see the picture, and you can see the final picture now with IVUS images in different sections, 1, 2, 3, and you can see how good quality pictures you have and good quality angiogram. The rhodoblator is the one which all of us are interested to know how it is useful, whether we can continue to use this or not, and what are the indications and how useful they are. You know very well more about this device. It produces 5 micron or less particles, which is cut because of 5 micron diamonds studded on the tip of the catheter. And with this, we are able to get a reasonably good result in very calcific lesion. And very often, this is the only device which would be able to succeed in those cases. You also looked at the option of why we need this, and we know we are more aggressive, and more aggressive we become, more and more calcium we'll have to deal with. There is an increasing prevalence of calcification in today's practice, even up to 34%. I heard somebody talking about the thickness of the calcium, and our Japanese colleagues have been very, very successful in enlightening us and grading what is severe, what is less. They have found out, as well as they have done a study which showed that any lesion with more than 500 micron thickness of the calcification, which has to be treated with a atherectomy device. So that is our cutoff point. In quick summary, the presence of calcium may lead to unsuccessful PCI, undilatable lesions, rupture of balloons, and various problems indicated here, higher incidence of major advanced cardiac event, and poor long-term results. So we modify the Plaque today, making the complex lesion simple, changing the lesion compliance, minimize the vessel trauma, and creating a larger MD. But we have not demonstrated this will improve the long-term outcome and reduce the restenosis. You know that rhodoblator pictures, there is a dense calcification in OCT, which is well demonstrated. Post-rota, you can see, beautifully, the inner part is cut and that calcium has been removed completely. This will make the lesion very supple and dilatable. This is one of our cases which has got a very severe calcific lesion, the ostium of the left main, ostium of the LAD and circumflex, and the bifurcation of the left main. You can see a bundle of calcium sitting there. This was treated with rhodoblator into circumflex and LAD, and we were able to finally achieve a very, very gratifying result. You can see it here. Then comes the flex stone, the cutting balloon. It has got multiple blades embedded onto the balloon surface, and this balloon will be used to cut the atheroma, can be used in moderate. The blades are very sharp. It is sharper. The atherotomes are sharper than even a scalpel, which you use in surgery. And you can see the lesion which is cut here. Like that, multiple cuts will happen on the in the vessel intima, and this will allow the vessel to dilate well, and we can deal with fibrotic, elastic, and moderately calcific lesions with this device. And the new device is excellent. It can withstand high pressure dilatation also, and we are able to avoid a lot of snow plowing and adverse complications related to that device. And we obtained an excellent acute as well as long-term result. There is a very similar principle. There is another device called the angiosculpt that also acts similar way and exerts pressure on the atheroma and the calcification on the intima, pressure all around, and we are able to crack the lesion in the OCT picture. You can see that, and this is the images we got after using an angiosculpt balloon. I heard you all talking about the orbital device, whether it will replace the rhodoblator. It will not. It is useful device, yes, in certain subset of patients. But only problem is the cut particles are much larger, 10 microns size. The cut particles much larger than the rhodoblator cutting, and it can damage elastic vessels also, and elastic surface also, and it can damage healthy surface also. There's one of our patients who had this device used. We got a very satisfactory result. You can see another patient with a long lesion from the proximal segment, which is calcific, which is treated with this device. And this is the pre and post. The post, you can see the vessel is cut. There is a lot of intimal disruption after using this device. And finally, we got a good result after stenting, because that made that lesion more supple to accept the stent. And OCT images show a very gratifying result. What is the major difference between these two devices? The rhodoblators, the cutting surface is at the tip, whereas Diamondback is on the side, and the cut particles are larger and these cut particles are smaller. But it is not as efficient as rhodoblator. Lithotripsy, I heard a lot of questions coming up because this is the new kid on the block. It's a very, very useful device. It is tissue selective, hard on hard tissues, and lithotripsy waves travel outside the balloon, designed to disrupt both superficial and deep calcium. Designed to normalize the vessel compliance prior to controlled pressure, dilatation, and effective lesion expansion and minimize impact on the healthy tissue. We have started using this device very regularly, and this device definitely produces significant amount of disruption of the calcific lesion internally as well as medially. This is the pre-procedure picture with dense calcification, post-lithotripsy, you can see the disruption, and post-stent with a very reasonable and acceptable lumen. This is the same patient. The lesion is the long proximal LAD. This is the post-lithotripsy and stent. This is the lithotripsy balloon opening and stent post-stent deployment. Pre and post. Another device we are now using is the excimer laser. This is also an extremely useful device in the densely calcific lesion, and especially in lesions with calcium behind the stent, producing underexpanded stent because of that. This can be used in various situations, but mainly significantly in calcified lesions. This is one of our patients, a doctor who had an angioplasty for the circumflex few years back, a few months back, but unfortunately the lesion was not open fully because there was dense calcium behind the stent, and this one we came back with restenosis, which was expected, and we could treat them with a laser catheter, take away the, we could treat that calcium behind the stent, and this was a post-laser, and this is the post-dilatation and a stent. So what we do in today's practice is a lesion modification, not calcium removal. The concentric plaque with superficial or circumficial calcium as well as calcium behind in the media, we try to modify with the use of all these devices we are using, and which would make a reasonably good dissection of the calcium or split the calcium, which will make us make an avenue for us to implant a good stent and good apposition and good long-term result. Now, in summary, how do I put it across? In our practice, what do we do today? If it is mild to moderate calcification, non-compliant balloon and opium balloon, any of these should be enough. Moderate calcification visible on cine, cutting balloon and angioscope are extremely useful. Severe calcification, a rotablator is a choice, followed by an NC balloon and stent. And usually we can get away with a 1.5, 1.75 bar, and very rarely a 2 millimeter bar. Very severe calcification with a vessel size larger than 3 millimeters. Then we need more than a rotablator, but we need a rotablation to prepare the lesion or pave the way to take the next set of devices in, because we know that lithotripsy balloon is very large, very bulky, opium balloon is very bulky, and all these devices are large, and it will not go through a tight calcific lesion. We have to use a rotablator to prepare the lesion, and then we can use, so is angiosculpt and cutting balloon. Any one of these devices we can use, followed by, preceded by the rotablation, and followed up at the stent. Very severe calcification in small vessels, large, lesser than 2.25 millimeters. My choice would be only rotablator and balloon, or rotablator followed by drug-eluting balloon. And severe calcification in large vessels with enough lumen to accommodate an orbital atherectomy, you can use an IVL or orbital device. As I said earlier, both orbital atherectomy device as well as the lithotripsy balloon are large devices which need space to start working. Very often we don't find that. Calcified long and tubular lesion, what do we do? My choice would be still rotablation followed by appropriate devices. With the osteal lesion, with the severe calcification. Cutting balloon, angiosculpt, followed by other devices would be good enough. Very rarely we'll need use of rhodoblator. Long lesions, diffuse lesion, as well as calcification behind stent, the choice would be ELCA and lithotripsy would be my choice. Under-deployed stent, again, lithotripsy and excimer laser would be the choice. And this would sum up what is the current practice guideline we can follow to have 99.5% success rate with a very low rate of complication, provided we know how to use these devices and in absolutely correct indication, it will be very useful. Thank you very much for a patient listening.
Thank you, sir. Sir, can I ask a question, sir? Dr. Samuel Mithu, thank you for your nice presentation. I'm Professor S. Mustafa Jaman. Actually, already you have presented nicely, especially for debulking method. But in the early stage of debulking method, balloon-based technique, when you did lot of cases, modified lot of calcium. So for our junior fellow, my question is how they will assess the plaque or calcium, and especially which type of balloon, lot of type of balloons already discussed by Dr. Mominuzzaman. So your experience, which type of balloon or which type of method, and how to assess the calcium?
No, now there are so many balloons available online, but all of us in our experience, we have seen that very often balloons are not enough. Balloons will not give us adequate dilatation. There will be so many, at least 20-30% of lesion which is not amenable for balloon, and so many cases where balloon will not even cross. So then we need something else. That is the indication or the development of all these atherectomy devices came because of the limitations of the balloon. If balloon was efficient enough, we wouldn't have needed all this. It is not. The higher restenosis, higher complication, and limited benefits, limited success as a primary procedure. So there, as I summed up, I bifurcated them into small vessel, large vessels, diffuse disease, and that would be the dictum I would suggest still. If you want, I can go back and show that slide again. I think we are running short of time.
Yeah.
No, I think so, sir. I can add something to your comment that most of the lesion, except the severely calcified lesion, that lesion can be tackled by either NC balloon, cutting balloon, or scoring balloon, and even the OPM balloon can be used in the case of some form of the severe calcium. So balloon can do a lot of the things, and other devices like rota, orbital, definitely they have some role in a specific subset of the patient. Otherwise, majority of the case we can deal with that. But before the coming to conclusion, we must, if we think that is severely calcified, we have to assess the calcium by imaging. That is most important. Because angiogramically, it is very difficult to assess the calcium. So we have to assess the calcium, how the calcium is length, how the calcium is thickness, and whether calcium 90, more than 90, 180, or like that. I think so. You will agree with me, sir.
Absolutely, Dr. Ramanya. You see, as experienced people like Paul know that is the honest truth, and which is correct. Those of you imaging are at a great disadvantage in today's practice. All of us should try to get an imaging system in your cath lab to make all these crucial decisions for a successful, acute, and good result.
Professor Subir Rahman, you have any questions, sir? Professor Subir Rahman? Because you should have some question of Dr. Matthews, because you work with him very hard time in Bangladesh. Professor Subir Rahman?
Yes, sir.
Sir,
you are right. You are right,
yes,
Professor Afzal. Initially, I used to really disturb Matthews, whether he is in India or in America or Europe. I used to make his life difficult because I used to carry even 35mm films also. But he was a wonderful man. Every time he encouraged me, every time he has guided me. In our time, we didn't have all these gadgets, you know that. But we did until today also. The balloon dilatation for the calcified lesions are, if you do it slowly, gradually and confidently, you can do it. But not all the cases you can get away with it. One alternative, they're going to ask Matthews that if he's got everything there, but considering our Bangladesh scenario, if we see anything like that, can we do the CT angio to find out what is the situation, or what is his advice?
CT angio.
Sophia, I can understand your question, and it's great being back with you all. And good old memories can be revived.
And Professor Subir Rahman also make my life miserable, because every month I have to go to the airport. So she forget that. Every month I have to take Matthews and I have to go to the airport to the custom clearance.
Yes, I know. But before that, I used to carry it, sir.
Yes.
And when I found that you can carry my responsibility, I gave it to you. You have done a lot for Dr. Allen, the Charles Chan, then Matthews, Cole. I know that.
Yes, thank you.
The generation will go like this. But what Matthews has done in difficult time, he came, but you will not believe, in a single. In a split of a second, he didn't discourage us. Any time we asked for anything, he was always friendly. And
yes.
For my moral boosting, I had a lot of problem, but for my moral boosting, he was the man. And Dr. Cole was also one of the person who had always encouraged me in for establishing this intervention in Bangladesh. You know that. But I just want to ask Matthews about this. Is there any role or what we should do? Not thinking in his background, we need to know in our background. Lot of fellows are there. We don't want. They don't have all the facilities. What even some of the hospitals in Bangladesh we have. So what they should do?
I have all my sympathies with the people who. Yes. That is the limitation all of us have.
Can't hear you. That's the problem. Next time, Afzal, give a headphone also.
Okay, sure. I will do that.
Thank you.
Am I audible?
Yes, audible, sir.
Yes.
But
very difficult, Matthews, and I couldn't hear you very nicely.
Tried my best.
Yes, now, yeah. If you bend forward towards your ear, now we can hear a bit better.
I will. And
yes.
See, CT angio cannot be a replacement for any of these devices. Identify the extent of calcium and the severity, and make a decision. It can only give you an indication whether calcification is there or not. That's going to make us wiser to select the right devices. But when you have no choice, you have no choice. I always used to say, Sophia, you also remember that God forgives and helps those who do not have.
True.
Okay, thank you very much.
True.
Knowingly we commit mistakes and you have the facility, then you pay a price. But others also will be helped by God. So we believe in that.
Okay, thank you. Mominuzzaman, I think so. You want to say something?
I didn't say that CT angio will replace anything, but I think when the juniors or fellows have got anything, or if they are thinking that it is too much, they have to refer to the places where they are doing these devices, and they can take out the calcium. So that's why I was thinking that. Because there was in the talk somewhere I heard this our young generation was saying that they do CT angio as well to find out the calcified burden. That's why I asked you about that. I know that this is because me and Hiraman when we first CTNGU came to Bangladesh, we did a study. We planned to do about 50 to 100 cases, but after doing 10 cases, we couldn't find any correlation, or it was not very much matching with each other, so we gave up. That's why I asked you. Thank you, Matthews. Thank you so much.
Thank you very much. Thank you, madam. Thank you, Matthews. Thank you. We always remember you. Your contribution is the top of the level. What because I am the direct vigilations in NSCBD.
Thank you.
And in Bangladesh, Matthews.
Thank you.
Yeah. Thank you, sir. Nice to see you. You are healthy. That is the most things that I want. There are a lot of memory with you. I don't want to express these things, but I salute always. I salute you always. My small question to you. So whenever I attempted to handle a calcific lesion after balloon dilatation, if it is unsuccessful, will it be wise to use rotablation at that time? Or if you plan it, do it from the very beginning?
Today it is safe. No. We know now. We used to think that it's not safe. Today I know for sure it is very safe to use.
Yeah. Thank you.
Okay. Thank you very much. Thank you. Thank you, everybody. Thank you. Now, can I request Mustafa Zaman? Can you call the?
Thank you, sir. Yeah. Thank you. Thank you. Actually, we are dealing with calcium, and very, very interesting session. And the renowned intervention cardiologists are presenting this calcium. And now I request Professor Fazilatun Malik. She will present a complex case with calcium management. Professor Fazilatun Malik.
Chairpersons, friends and colleagues, it's indeed a great pleasure and privilege for me to be here today. Now, we all understand that coronary artery calcification is age and sex dependent, and coronary artery calcification means trouble. Why? Because it increases the risk of procedural failure and complications, and it also, when we want to take a stent, there might be difficulty in stent delivery. During stent deployment, there may be under-expansion, asymmetric expansion, and malapposition. So when we see heavy calcium, we really need to tackle it. And indeed, as has already been alluded, that there are loads of tools to do this. But for me, I think for most of the lesions, when there is a heavy calcium burden, be it localized or diffuse, and if it's in a small caliber or large caliber vessel, for me, the best option is a rotablation. And I would like to show a few cases just to illustrate this. Now, this is the case of a very elderly lady. She had multiple comorbidities and she was refused surgery because of her frailty and her comorbidities. And as you can appreciate, she has poor ejection fraction and has a very severe aorto-ostial calcified lesion. And the calcium extends into the LAD and the ostia of the LCX as well. Now here we cannot take a balloon, obviously. We cannot afford a long-time procedure. We have to be swift and we have to be effective. So what we did is the rotablation was our only option, obviously. We rapidly wired the left main to LCX and we did rotablation from left main to LCX, targeting the ostia of the LCX. After that, we took the wire to the LAD and we did rotablation from left main to LAD as well as the proximal part of the LAD, which was heavily calcified. After rotablation, we did pre-dilatation and then we took a single stent from the ostia of the left main to the LAD, dilated it, did post-dilatation, did proximal optimization. Our patient tolerated this procedure and this was the final result. Now, another subset of patients who have a huge calcium burden are kidney disease patients, as you would agree. And this is the story of an end-stage kidney disease patient who is on dialysis. And you can see that his RCA is heavily calcified, and to top it, it's a CTO. So after opening up the CTO, we needed to tackle this calcium if we wanted to do anything. And you can see the calcium even on angiography. So our choice was obviously to do rotablation here. We changed for a rota wire, and then we did rotablation, first with a 1.5 millimeter burr, and then with a 1.75 millimeter burr. And we did it systematically, and as you can see, almost the entire vessel had to be rotablated. There was such a lot of calcium there. So after rotablation, and as Dr. Matthews was saying, he is my mentor as well, plaque modification is the target. We don't really want debulking, we want plaque modification. And after plaque modification, we went on to do pre-dilatation. First, we took a 2.75 by 15, and then we took a 3 by 12 NC balloon. And we systematically did pre-dilatation through the calcified parts. After pre-dilatation, only then, when we were pretty sure that our stent would go and it would deploy as well, did we take our stents. First, we took a 3 by 38, deployed it. Then we took a 3.5 by 30, deployed it. And then we did post-dilatation. And this was the final result. So rotablation can give you excellent results like this. Another subgroup of patients who end up with heavily calcified vessels are post-CABG patients. And that was the story of this 60-year-old gentleman who had undergone CABG 2 years back. Now, he gradually started having chest pain again, and so an angiogram was done. It was found that, unfortunately, all his grafts had occluded, and his native vessel was pretty diffusely diseased. There was left main disease, and there was a lot of calcium. So this is how his native left side looks: severely calcified left main stenosis involving the proximal part of the LAD. We did this case like 6 years ago. I think that's why we have a TPM lead. Nowadays, we do not take a TPM lead regularly. The right side was also a large size dominant vessel, but it was also diseased diffusely. So what we did, we first treated the right side. And this is the final result on the right side. After treating the right side, only then did we go to tackle the left side. Now, on the left side, you can appreciate there's such a lot of disease, and there's a huge chunk of calcium sitting there at the distal part of the left main. So what we did, we attempted to wire the vessel. However, we had some problem in wiring the vessel because there was this huge chunk of asymmetric calcium sitting at the ostia of the LAD. So we took a micro catheter, a fine cross, and with the help of the fine cross catheter, with gentle negotiation, we were able to wire our wire and pass it into the distal part of the LAD. We exchanged our wire for the rota wire with the help of the fine cross, and then we were in business. So we started rota ablation. We did rota ablation first with a 1.25, the intent being for plaque modification. After this, we were able to take our IVUS catheter. Before this, it would have been futile to take the IVUS catheter. It would not have gone, and it could have destabilized our patient. So we had a look with the IVUS catheter, still a lot of calcium, around 270 degrees of superficial calcium. And so we went with the 1.5 per now. After rotablation, we decided to have a look with the IVUS, and we were very happy to see that the ostia of the LCX was free of disease. So as the ostia of the LCX was free of disease, this was good news to us. However, the left main showed significant disease. We decided on a simple provisional stenting. So we took, after pre-dilatation with NC balloons, a 4 by 34 stent from the left main ostium to the LAD. We deployed it, we did post-dilatation, and this was the final result. Now, frailty is something that we are seeing more and more. And so this is the story of an 82-year-old really frail female patient that we had. And just looking at her would stop your heart because she was so small, so sick, and so frail. And she had multiple comorbidities. She was diabetic with CKD, with COPD. She had very severe angina, which was gradually getting worse. And so she had to be hospitalized with unstable angina in another hospital. They could not control her even with maximal anti-anginal therapy, and so an angiogram was done. She had severe triple vessel disease, calcified vessels, including the left main. The surgeons in that hospital, considering her frailty, her age, and her comorbidities, were not keen to do CABG on her. So she was transferred to our hospital for revascularization. Her ejection fraction was 48. So considering the fact that she was elderly and she had CKD with a serum creatinine of 2.8, we decided to tackle the right side on the index hospitalization day. She tolerated the procedure well, and we waited. 5 days later, we decided to tackle the left side. And as you can appreciate, even on fluoroscopy, you can see the calcium burden on the left side. And this patient would not be tolerating a prolonged procedure. We had to be gentle with her. And there's severe disease involving the distal left main, the LAD, the LCX. So what we did is we first decided to do rotablation from left main to LCX with a 1.25 burr. After that, we went on to wire the LAD and we did rotablation with the 1.25 from the left main to the LAD. We had a look with the IVUS now, and there was still quite a bit of calcium burden there. So we stepped up our burr to 1.5 and did rotablation with that. This is the angiographic shot that we took after rotablation. So for this patient up front, we decided that we would be doing a double stent strategy, and we chose the DK crush technique for her. And after the DK crush technique, this was the final result. And actually, this case was done like 1 year, 6 months ago, 82-year-old lady, and she's doing well now, touch wood, and is leading a fairly active life. So this is the miracle that, revascularization for elderly patients who have already been refused surgery can really be of paramount impact on their lives. And in fact, we have been doing rotablation at National Heart Foundation on a fairly regular basis since January 2015. And from January 2015 to September 2020, we've done a total of 240 cases. Of these cases, more than 75% of our patients are above the age of 60. And as you can see, almost 30% are above the age of 70. If you consider the sex distribution, 74% of our patients were male and 25% were female. And these patients were really sick. They had multiple comorbidities. 67% of our patients had diabetes. That's a huge number, 67. 92% were hypertensive. 58% were dyslipidemic, half of them were still smoking, and 61% had moderate to severe CKD. And quite a few of them were on dialysis. And regarding the type of lesion, 85% had diffuse calcified lesion in narrow caliber vessels, and the mean lesion length was 42%. So here, you wouldn't do much with cutting balloon or lithotripsy. You needed to, really take care of the entire calcium. And these were really complex cases. From the 240, in 185 of our patients, these were real complex cases. 22 were post-CABG, 37 were post-PCI, 6 were post-CABG and then PCI, and again they've come. 92 were left main disease, and 28 were CTO, where after opening the CTO, we did rotablation. We've managed to follow up our patients, and our mean follow-up is around 30 months, and our overall MACE is 10%, 10.8%. So our take-home message would be that patients with calcified coronary artery disease often tend to be elderly with multiple comorbidities, and they are often poor candidates for bypass surgery. Their vessels tend to be diffusely diseased, heavily calcified, and of narrow caliber. Rotablation is an effective technique to tackle such complex calcified cases, and after rotablation and proper lesion preparation, the newer generation drug-eluting stents can obviously optimize the outcome. But the most important ingredient to do complex cases like this, as I always say, is the teamwork. And from the entire team of National Heart Foundation, I would like to say thank you for giving me this opportunity to present this. Thank you.
And nicely demonstrated, nicely elegant cases, I will say that. This is beautiful case, complex case, and tackled it very nicely.
Okay. Sir, may I
yes,
ask a question?
Yes, sure. Because
Thank
we
you,
are
sir.
looking for you. We are looking for you. That's why.
Thank you, sir. Ma'am, I have a simple question. When you decided go to directly to the rota, or you try balloon first, then when balloon is failed, then you go to the rota. How can you assess this one is directly should go to rota, and this one is try balloon and then go to the rota? Ma'am, thank you.
But thank you for your question. But the cases that I've shown, all of these cases, the amount of calcium was so much that the decision was obviously very easy to make, right? And another thing is, most of these patients were very elderly, frail, and you really can't, like the aorto-ostial lesion, really take a balloon and sort of give a test run with the balloon. So obviously, I had decided there from the very beginning that we would need to do rota there. And when there's a heavy calcium burden, from the very beginning, we usually decide that we're going to do a rota up front. Sometimes, maybe the calcium is not that visible, but when you're wiring and then you have problems with the balloon and all, then also without creating any dissections, we decide to switch to rota. So if there's problem, and always if there's like mild or moderate, you think the wire went easily, not like this heavy calcium that you can even see visually, but you have any suspicion, then you can always do imaging and sort of make sure that the calcium is more than 270 degrees, and you think that it would be a good idea to do rotablation. So in severe cases, upfront we decide. In cases where we have doubts or we were planning to do a straightforward angioplasty and have got into trouble, we usually try to do imaging.
Yes, this is very, I think so. This is the take-home message. I think so. The Chillor has pointed out right question that before going for any devices, we must be certain about the severity of the calcium. That Fozila nicely demonstration that it could be the angiographically, but it is angiographically very difficult. But if you have a imaging in your lab, you should assess it. Then you can proceed it. Otherwise, sometimes the late case, what Fozila says that case should go for without any imaging, because if you go for imaging, that patient may collapse in the table. That's why she assessed angiographically and go for the rota. I think so. That was, I think so. That's an elegant decision. And is there any panelist or any comment?
Sir, I have a question, sir. A little question. Actually, we are dealing with calcium, and Madam is actually presented nicely. But my question is actually we are mostly dependent with technology along with technical dependency. So. Any difference in radial or femoral in dealing with this type of case, or any catheter, or, by radial case, sometimes we do not use actually 7 or 8 type of
No, actually, if you are using a 1.25 or a 1.5 burr, because you're doing plug modification, it can be done through the radial route, a 6 French catheter. So radial route is not a problem for doing rotablation.
But if you are not comfortable, then you can, if you have taken the more larger bar, you should go for femoral route.
Yes.
So if you are comfortable with the femoral, go for femoral. If you are comfortable with the radial, go for the radial. Even I have seen that that is unknown situation, the Saito in the lab of the United Hospital, I told him that which route now is comfortable. he said that this is an unusual situation, it is better to go the femoral. So not necessarily always you have to go to the radial. You have to choose yourself, situation, circumstances, and what is the ability is available now. So it is the life of the patient. Is there any question from any of the panelists? Only Jillur was there, but other panelists were there.
May I ask a question, sir?
Yes.
Sure.
Madam, you nicely demonstrated. I have a simple question. If you fail with the different size of rota bar changing, then the calcium is not gone. Then what's next? What's next step you follow?
No. Actually, actually, once you've done a thorough job of the rota ablation, then you do pre-dilatation with NC balloons. And you do a thorough job of pre-dilatation with NC balloons. And once you've done rota ablation and then pre-dilatation with NC balloons, touch wood, in our 240 cases, we have not had any problem so far. And Dr. Matthew, I think already showed pictures where the rota actually cuts the vessels, so it makes it very soft actually. So when you're doing balloon dilatation with the NC balloon, you can then take the stent. Usually there should never be a problem.
Fazila, what Anisul is the question, because there is a lot of the webinar is there. There is one proctor in the outside. They demonstrate that they failed the rota, but they done the case with the lithotripsy. That's why he raised the question, I think.
Okay, so. Right. But for me, for 240 cases, I never had any problem with rota. But I suppose the proctor who is a proctor for lithotripsy, maybe there was, a small nodule of calcium.
And that's right.
A very, very bad nodule, and maybe he could not remove or could not do proper plaque modification with the rota ablator, so he used the lithotripsy. Maybe something like that.
Okay, thank you very much. Is there any question from the panel?
Sir, can I ask?
Ashish.
Probit. Yes.
Ashish, sir.
Ashish. Okay, Ashish.
Madam, I have to question a simple question, because we don't have any rota or any other devices that you have used. We are in the Chittagong and also other, except Dagar, no rota patient. For junior and also as for us, how can we detect it is superficial calcium or deep calcium, or is it dilatable by cutting balloon, or is it by angiographically only, because we don't have any other devices?
I think so. I can add that it is the imaging. You have to go for imaging.
No, we don't have any imaging and any other.
And it is very difficult angiographically. The calcium is visible angiographically. That is usually hypercalcium. Usually.
Superficial calcium or deep calcium, or it is.
You have to go for imaging, and otherwise you have to send the patient to the center where they are doing the imaging.
Sir,
Fazila?
It's in a, not fluoro. Somebody tells it is superficial calcium, and if it is rail trick type, it is deep calcium and it is severe calcium. Is there
better you send the patient to madam?
No, shall I tell you something? Okay, like you wired the vessel and you're taking your device, okay, and your device doesn't go. Like you're taking a 2x10 balloon and it's not going. So you understand that there must be some problem. Why is my balloon not going? There must be some calcium. Then there must be some superficial calcium. So when your hardware doesn't move properly, that is also an indication that there is calcium present there.
But that is during the procedure. His question is that before the procedure.
Before the procedure, just by looking at angiography, in the vast majority of cases, you get an inkling that there is calcium there, right? And sometimes it's so gross that you can just see it in the fluoro. But sometimes you might miss some calcium. And that's where imaging comes in.
If you see the calcium, both of the side, that is lateral and medial side, and it's both distal and distal, that is the severe calcium. If not, that is then, this is an assessment. And during the procedure, you can use the non-compliant balloon. If the non-compliant doesn't inflate, then you should not proceed much. If you really want to do that, and balloon is not inflated, then you should not do it in procedure. But before that, you have to assess the severity of calcium. Imaging is important. So I think so imaging is not a big deal. In Chittagong, there should be an imaging. That's not a problem. Ashish, you should forward for that, because you are holding the Chittagong Medical College. And I think so we have another panelist. and he is an Abu Salim. Would like to say something? Salim? Abu Salim? No.
Yes, sir. Sir, thank
okay.
you.
Would you like to say something, or we can finish the session?
I have a small inquiry. I want to know the experience of madam. You're doing lots of severe calcified case for our young fellows. Is there any advice where to stop? Which case we should not deal if there is severe calcium assessment by IVUS? Yes, the calcium level, and is there?
Open your video, please, camera, Salim.
No, he is no problem.
The question is complete.
Fazila, he said that when you stop.
When to stop?
The calcium.
But if your vessels are calcified and you have the necessary tools, you should go ahead and do the procedure, right? And you do it effectively. You don't need to stop, because these are the patients who are the most sickest. Where do we see calcium? Calcium is age and sex related. So you're seeing calcium in a very sick patient, or a patient who has chronic kidney disease. So these patients, in many instances, have already been refused surgery because of their comorbidities. So here you need to do the procedure, but only when the necessary tools are available and the team is also ready to tackle this difficult case. If the team is not ready, if the tools are not available, then just to go and do a balloon and then dissect the vessel and then not be able to take a stent, that should not be done. So if the tools are not available, you should stop. But if the tools are available, if the team is well prepared to manage this type of complex case, then you should go ahead and do it.
Otherwise, you should refer the patient.
You can benefit. You can give great benefit to your patient.
We have to think about the. I am agree with Fazila that we have to think about the benefit of the patient. We should not. We have to know when to stop, when to give up. Now we are out of the time. Now this is the time for the chairperson. There is a fourth chairperson, and a short comment, please. And
sir, my apologies, sir. Our foreign faculty are actually in rush in time. If you try to wrap up the session very shortly, that would be better for next session. Thank you,
understand. Sir. I understand. That's why I'm telling that. And is there any Zaman? I think so.
Yeah, start by our chairperson, please. Professor Sufia Rahman first, or any Matthews, or Cesar, Mamunur, Cesar, and other. One by one, please. I'd request persons.
So I think, Sufia Rahman, you should
conclude the session.
No problem. If I can get the first chance, no, not bad. Anyway.
Okay.
What I was going to say that every district now you should try to have the imaging. The question it was asked, and Fazila is nicely presented, and she also mentioned that she didn't have much problem. Usually, if it is not very much distal calcification, which is very, very rare, with the comorbidity and the age of the patient is very important, and if you mentally you are prepared for that, you will get some sort of calcification if the patient is 65 above and have comorbidities. Most likely you might get it, but mainly if it is octogenarians, 80 years or more. But the proximal lesions, I think more or less with the rotablator, they can clean it nicely. They get rid of the all calcium. Usually there is no problem. But I have seen in our time also, Matthews are doing it. He is one of the best operator in the world, and he has really shown us at that time also. And the bars must be very latest now, and that should clear up all this. But I think that now we are from traditional, all what we are doing, this is very good, but imaging is going to help us a lot. And no doubt about it, regarding the size of the lesion, regarding the length of the lesion. I think we should try to get all these at least away from Dhaka. Imaging can be easily done, and from there you can always do the next what is best for the patient. all these speakers has really presented excellent. I mean, each one of them, the subject they've chosen, they have really presented nice. Due to the shortage of time, I'm not going one by one. What I'm saying that all of them are presented very nicely, and we are lucky to have them in our this session, and with all juniors and seniors. It was a get together as well for me for after a long time. And I hope this will continue. But as I carried on, give it to you, all of you, you should also try to teach your expertise to next generation as well, so that they, more you teach, more reach you are. You don't teach, you are not that rich. So you should teach them practically, and then let them work, and you will see what from one person in Bangladesh you have become 300 plus now. So from this 300 plus, it should be very soon 1,000. So for that, I think we are unfortunately in Bangladesh, we don't have that much of resource like other people, other countries. But I think now people has realized that we can do world-class job in our country. We have got all the personality, we got the expertise, and we need some hard tools now. And that can be encouraged. Whatever institute you are working, they should provide these for our interventional cardiologists. Thank you, all of you, and for organizing such a wonderful session. Thank you again. And Dr. Afzal, if you don't carry those catheters, you would not have that interest to have an interventional cardiology.
Okay, thank you. Thank you, madam. Thank you for your compliment. So with this, we can come to conclusion, or is there any chairperson who will say something?
With other not, we don't know. Matthews.
Okay.
Matthews. Samuel.
No, Matthews finished. Mozumdar sir say something. Mozumdar,
sir.
Mozumdar? No.
No. I think you can finish, sir.
Okay. No, with the permission of the chairperson, I think so. If Mostamazamani agree with me and all the speaker, now we can finish the session. Thank you. This is a really great session. To hope to see you very soon with the new session. Thank you very much. Thank you very much.
Thank you.
Thank you. Bye bye.
Now I'm requesting Professor Mahbubur Rahman and Dr. Khaled Mohsin, please continue the next session. And Dr. Arun, are you there?
Yep, very much so.
Okay, fine. Okay, our moderator introduce you, and they will run the program. Okay.
Thank you, Dr. I welcome you all to this session on chronic total occlusion intervention. It was scheduled to start at 6:30, but we are running about 50 minutes late. So let's get started without wasting any time. As we all know, that the CTO intervention is one of the most difficult terrains of interventional cardiology in the aspect of patient fatigue, operator fatigue, contrast overload, and unpredictability of outcome. So we need to master this technology in a different way. And my co-moderator is Dr. Mahbubur Rahman. He is the Senior Consultant Cardiology of LAB Cardiac Hospital. And we have 4 chairpersons. They are Professor Maximul Haq of Ibrahim Cardiac Center, Professor Dr. Shams Monwar, Evercare Hospital, Dr. Ramesh Dagubati. He is an Associate Chief of Cardiology, University of West Virginia, USA, and very closely associated with SKY. And Professor Muhammad Tawfiqur Rahman is a Professor of Cardiology, M.A. Malek Medical College, Manikganj. And we have 7 panelists as well in today's session. Dr. Shamir Kumar Kundu, Associate Professor NICVT, Dr. Muhammad Tawhiduzzaman, Senior Consultant Cardiology of Square Hospital, Dr. Kajal Kumar Karmakar, Associate Professor of Cardiology, NICVT, Dr. Noor Alam, Associate Professor of Cardiology, NICVT, Dr. Bijoy Datto, Assistant Professor of Cardiology, NICVT, Professor Dipankar Nag, Professor of Cardiology, National Medical College, and Dr. Mir Nasaruddin, Senior Consultant Cardiology and Associate Professor, National Heart Foundation and Research Institute, Dhaka. So let's get going with the first topic. It will be delivered by Dr. Arun Kallan Sundaram. He is a Cath Lab Director, ProMed Hospital, Chennai, and he will be speaking on CTO PCI, common and difficult scenario. Over to Dr. Kallan Sundaram. Arun Kallan Sundaram.
Hi guys, hope you can hear me and hope you can see my screen here. So first of all, thank you so much for having invited me to this wonderful meeting.